Thank you, and I have to apologize. I know some of you in the room, but by habit, I'm a pig veterinarian, and so you can all leave now if you want to talk about that. I'm actually a pig veterinarian by accident because I wanted to live in Illinois, and if we want to work in intensive ag in Illinois, we're going to work on pigs because that's what's there, not cattle. So I've had an interest in feedlot and actually get to interact significantly with a group, the Production Animal Consultation Group in Nebraska. In Kansas and work in large feed yards today. About 15% of the country, 15% of cattle on feed we're working with. And so the data you're going to see today is actually coming out of that group, large-scale feedlot size. But that's not why I'm here. I'm actually here because we got interacting with the BRD cap and really this question about how do you accurately identify phenotypes if you're going to do genetic typing. And so in the pig world, we've had to been forced to think a little bit differently because Dr. Williams was just talking about how do we define BRD and all these herds and producer definitions. And so in my previous life, it was not uncommon we would work with 300 to 400 people taking care of pigs on various sites within a given system in a given day, which meant our definition of the appropriateness of disease detection that day was somewhere, the number of definitions was somewhere between 300 and 3,000, depending on actually how many sick pigs they identified. And so that really started to drive some thought processes in us to say, how do we solve this wicked problem? Because if you think about improving production in a systematic manner, very much like an engineer would think about it, we have to accurately measure the system to start. And if I can't start with an accurate diagnosis of what the heck is wrong with the critter, I'm never going to be able to drive an evidence-based decision to the bottom and influence those outcomes in a positive manner because I'm not accurate on what I'm doing in the front. So that's really how we started today, how I got here and how I've been thinking about this. So we've been working on this a long time, thinking through it. We're at the beginning, not the end, but just want to click through some of this today with you to share some of our thoughts about how are we trying to improve what we're talking about so we can at least all speak in the same language to move that forward. So, as I suggested, this is quite a team effort. I'm the dog and pony show today, but large group at Geisler Tech, which is going to show you some of the technology today, our group with Production Animal Consultation, then our group at Illinois, working back and forth on how do we put these ideas and plans together to collect the information. So this is kind of the obvious, right? Critters get sick when they show up in a yard. And most of that's respiratory disease. It doesn't mean we're any better at it. So how do we deal with that in a manner that allows us to drive forward? So if we think about morbidity and the timing of morbidity, Dr. Williams showed some data about what's happening in those calves, right? 20, 30 days and then 140 days. This is, 250,000 treatment records over a couple of years. Somewhere 75% of those calves are some that are getting sick in the first 50 days on feed, with about half of that occurring in the first 24 days. Again, not shocking, right? We mix healthy and sick animals together, we stress the heck out of them, and they get sick. Shocker. Not news, folks. The problem is we aren't any better at this. I could show you this from 2013, 2012, 2005, 2001. It looks the dang same. We haven't made progress. And so we are attempting to try to move that ball forward, and that's what I want to talk about. Now, I think, and this session's been great, right? We've talked about management practices, we've talked about genetics, we've talked about a lot. But this is really one of my favorite quotes, right? We can think about treating the disease, and I see veterinary students in the room, and we think about teaching veterinary students names of bugs and names of conditions, and we kind of forget that there's a critter attached to that. And in production agriculture, there's a system attached to that, right? I don't think about one critter, and I really don't think about a pen. I'm really thinking about all 50,000 head in the feed yard, and I'm going to turn that 2.5 times this year. So I'm really thinking about 125,000 head of cattle I have to deal with. And oh, by the way, there's people attached and feed truck drivers attached and some dude buying cattle for me attached. And so how does that system fit together? And therefore, how do we think about it systematically to drive change and not just, these cattle show up today, I need to give this vaccine? I think we've already heard this afternoon that some of those vaccines may or may not be very effective. Which we would tell you in the pig world, I can't figure out which vaccines actually make us a lot of money except for one. We keep using them. But we can document one vaccine makes us a lot of money, PCV vaccine, but the rest of them, we can't document that we really can create this vaccine efficiency effect on a repeated basis. We think we do, but we don't know. So how do we treat the whole disease? And so what I want to talk about today is what we're going to call an inquiry-based approach to BRD management. So we think about BRD, right? Cow in chute, standing there with a fever or with some clinical sign, and right, this 60% accuracy on detecting BRD might not be quite that good. If we really look at a lot of data over time, it's highly people dependent. So if we think about BRD, but we actually think that there are three things that actually describe what the outcome of that BRD process is going to be. Right? We've got which bugs are there or which pathogens, and we'll talk about these bugs. We've got what happens or what's going on with the immune system, and then what's going on pathologically with tissue changes. And the interaction of those three things really determines what happens to that calf, whether he makes it or doesn't make it, whether he grows efficiently or doesn't grow efficiently. So if we think about these things, right, we can break those down actually a bit further and think a bit deeper. So if we think about the bugs, right, we spend a lot of time talking about pathogens, and I'm going to argue today this is not that important. People ask me what a feedlot cattle get exposed to, and I say yes. What does that calf have? Yes, he has that. Whatever you want to tell me, yes, that's what he's probably been exposed to. Guess what happens in the pig world? What have they been exposed to? Yes. The disease, the pathogens aren't that different. They're all basically exposed to the same. We know very little about this normal microflora bucket. We're spending a bunch of time trying to understand that today because of fancy-smancy technology. But the things that are probably interesting to us, what's going on with the immune system, and we've talked about systemic immune system, but we're really interested in what's going on locally, what's going on with the mucosal immune system response. We're not very good at measuring that. We're making some progress at both the gut and the respiratory tract. There's also some pretty good evidence today to suggest that what goes on in the gut affects the respiratory tract and vice versa. So respiratory disease probably influences gut health, and gut health probably influences respiratory disease. So this is pretty interesting to us. And then we don't spend a lot of time looking at tissue changes, but we think that's pretty important as well, right? So what's going on both mucosally and locally, and we're talking about BRD, so what's damage is going on in the lung, but then systemically what changes have happened, and what impact does that have on the outcomes of these cases, and therefore how do we direct therapies really at the end of the day to move that forward. So we've talked about those three big buckets. As I suggested, this is probably, we make a big deal out of this, but it's probably not that important in the overall outcomes. The virulence factors, etc., are probably not that different. So we're going to try to focus today on one, how do we measure host response? And we're going to talk a little bit about what we can do practically very, very efficiently today in the yard. That cattle, we have a big advantage in cattle and not in pigs. It's one of the reasons I've started monkeying around in the feed yards, because we've got much better data to work with. We need to think about what's the role of this microflora, and I'm not going to talk about that today, but I think this is what really the next level of approach is going to be. And when we go stick antibiotics in these critters, what are we doing to that microflora, and what interplay does that microflora have with the local host immune system? That's a big field. We know there's a lot of crosstalk, but that's really all we know today. But that's a big area of impact. And then really what I want to spend the rest of the time talking about, how do we use data, collecting this data, how do we use that to change outcomes? I'm a big outcome guy. Like, I'm not a big theory guy. Like, I really don't care what the theory is. Like, well, theoretically, this should work. No. Just tell me, did it change the economics of the situation today? If it doesn't change the economics, I don't care. I don't mean to be rude, but we keep score with dollars. I have a production background. I told you I'm a pig veterinarian. I'm really a pig farmer by habit. And so I think very much economically. And so if it doesn't change the economic outcome, I'm not interested. Probably not even interested in thinking about it, let alone talking about it. So, what's the basis of that? And so we would say, if we can think about that, we can really build what we're going to call an enhanced case definition. And our enhanced case definition really has 4 key parts to it. And so we use these case definitions then to drive our therapeutic approach, because we can track, once we have them adequately categorized, we can track those prevalence of those case definitions and the outcomes based upon those case definitions to determine if our therapeutic approaches or our preventative approaches are correct. So what comprises that? So it's a pretty simple thing. There's 4 parts. How severe is it? How long has it been going on? which organ system's involved, and what's the pathology in that organ system. So is it kind of bad, really bad, or holy crap, right? You don't have to make it complicated. We got to get this to somebody in the field who can make the decision, who probably doesn't speak our language. So I have to make it simple enough, good, bad, ugly. Has it been going on a little bit of time? Has it been going on a long time? Is it the lungs, or is it the belly, or is it the feet? And in the feed yard, that's really how we think. I will tell you that we radically improved case fatality rates for pneumonia when we actually started treating the ones with pneumonia and treated the ones with bad feet for bad feet. Draxin somehow does not fix toe abscesses. I know it's shocking, but this is real-world stuff. It's shoot-calf interaction. Cowboy says calf shows up, has fever, therefore must have respiratory disease, and our case fatality rate's high. The problem wasn't that the antibiotic didn't work. Guess what the question was? Doc, we got to change antibiotics. No, dude, we got to clip their toes. Y'all laugh. And it is kind of funny. But this is the stuff I beat my head against the wall against every day. And don't tell me you don't either, because you all do it. So, which organ system's involved, and then what pathology is occurring in the organ system? In order, severity is probably important, chronicity is important, getting the organ system right is really important, and this pathology is kind of a vetty thing that helps us, but isn't critical. So if I can get it to the lung, and I know if it's acute or chronic, that helps me a lot in guiding therapy. Because I'm pretty sure the ones that are chronic aren't going to recover very well, right? Like, what's the biggest success for improving BRD response? Treat them early. All of our farmer friends in the room, I don't mean to rude you, it doesn't matter which antibiotic we use, as long as we treat them early. So early identification is the ticket. And so in this manner, if I don't know if they're acute or chronic, and I'm only saying they got lungitis, I can't go back and help my people. Remember, I'm working in a system. I can't go back and help my people figure out that they're pulling calves late. So we use these accurate case definitions not just to guide our therapy, but really to guide our training process with our cowboys. To say, wait a minute, Johnny, every calf you pulled is a chronic. What are we doing here? We got to go find you. We got to teach you how to pull these cattle earlier. Because that really determines our success or failure is, does the guy on the back of the horse find the calf early? And if we can do that, we can use this information for training. Again, we're treating the whole system, not just the calf. So, how do we do this? How do we use it from a data standpoint, which is where I come in? I'm the computer nerd in this project, right? I don't spend a lot of time on horseback. It's not a pretty sight. I'll just be up front with that. There are still some giggles every time I get up there from my buddies, so just let that go. But what do? So we assign case definition, right? Then we measure outcomes, and then we can modify interventions. And when we started this systematic process, measure, model, fix, which is if you talk to any engineer, that's what they're going to talk about. Measure it, model it, then fix it. We as veterinarians are trained to do the opposite. Fix it, and then maybe measure it and model. What's that? But working through that process systematically within any system, whether it's big or small, radically will improve the outcomes that are going to happen. So how do we do that? We've got to know what it is, measure what happens, and this is the big advantage we have even over our human colleagues. Their case follow-up is pretty limited if they're not in the hospital. Pig world is somewhat limited because we have to kind of think about them at a barn. Cattle is great. We've got an ear tag in every one, and so we've made a lot of progress because we can measure individual outcomes and then use that to drive these decisions here. So, what can we do to measure? What have we got today? Do we have any tools to assign those things? I'm going to argue we have two tools today that are readily and commercially available that work very efficiently, and I'm going to support that, show you some data to support that. One, we can measure systemic immune response. Repeatedly, reliably, and very quickly. And you probably all do it every day. It's known as the fever stick. The thermometer, right, is a pretty accurate indication of what's going on systemically with the immune response in that calf. So if a calf walks in and doesn't have a fever and yet has obvious signs of respiratory disease, is that good or bad? It's probably bad, right? Because what's he not doing? His systemic immune system isn't working. He's failed to turn on kind of the basic immune system, right? We have to have a signal, cytokine release, brain resets the body set point, right? So we have to go from the local lesion up to the brain to raise temperature. That's a pretty systemic response. So I can measure kind of crudely his systemic immune response today, with a $1.29 implement from Walmart. Okay, that's pretty good. We can handle that. I can capture that data. We can do that fancier, right? We can have one that's hooked up with RFID tags and all kinds of jazz. But I can do this pretty simply. We do it every day. So we can measure this, so that's progress. We can also measure what's really going on locally, at least with lungs, with disease. And so there's been several models approached there. One of those would be, right, using an ultrasound. We could ultrasound those lungs and look at that. That appears to be pretty good in dairy calves where there's a lot more chronic pneumonia. We would argue if you're going to be successful treating those calves, that if there's that kind of pathological change, you're probably already too late. We're looking for really paracute changes. So the other tool we've got is a stethoscope. And I realize that is highly controversial, and I will tell you, if there are 150 people in this room today and we listen to the same calf, there will be 350 interpretations of that. That's a problem. So the group at Geisler Tech and really the guys at PAC said, hey, wait a minute. This is an opportunity we have. How do we fix that? And so we've spent a fair amount of time trying to sort that out and say, how do we use technology to get over that hump? And I want to talk a few seconds about that not because of the technology itself, but to show you as an example how we took technology, applied that to a specific case to radically change what was going to happen. So this is their technology. It's a whisper stethoscope. It's really no big deal. It's a microphone. It looks like a stethoscope, and that's just for our benefits. It doesn't actually have to look like one. It's a microphone that captures lung sounds. Then there's the secret sauce is there's a algorithm that actually evaluates those lung sounds, right? Just takes a sound recording, runs that through sound processing and says, this is this. Similar to what the voice, right? You've all got phones in today and they've all got voice recognition software on them, right? Same basic kind of technology, pretty simple stuff. That's been correlated back to basically an outcome-based approach to say that a 1 is normal and a 5 is chronic, and these are completely arbitrary conversations. But how this got matched up is that 2s are twice as likely to die as 1s. Not really complicated. They're completely arbitrary scores. And the goal wasn't to say, oh, well, these 3s, we really need to differentiate between a 2 and a 3. No, we just need groups that are different. They don't have to be perfect. They just had to be different. So now I can create a case definition, right? Because now I can define, remember my first two things are severity and chronicity. Well, if I've only got a stethoscope and I've only got one tool, I probably have to lump those things together. But I can fairly quickly start to differentiate at least between the normals and the really bad, really, really chronic ones. And then in the middle here, I can start to get some buckets to put things into. So what do I do with that? So we actually went in and looked at a whole bunch of treated cattle. Right? Cattle showed up in the yard, cattle showed up in the hospital, put a stethoscope on their chest, put this whisper stethoscope on their chest, put a thermometer in their rear end, and then we looked at outcomes on those. So if you just look at fever, we can explain about 18% of the case fatality rate, the difference in case fatality rate with fever. That's not very good. Might be a waste of time. So if you're going to put a fever stick just in them, and that's all you're using to decide if they're going to die or not going to die, it's not very accurate. By the same token, if we just use a stethoscope, it's a little better. I mean, it's 30% better than this. It's 23% of the variation. But even that's not very good. And think about that. We're trying to measure two arms of our inquiry-based approach, right? What's going on locally in the tissue, hence the lung score, and what's going on with systemic immune response, temperature. So if we combine those, we actually, adding temperature to the whisper gets us a 50% improvement over just using the whisper alone. But more importantly, we're 136% more accurate when we combine those two modalities and the prediction of case fatality rate at the time of treatment. We now have a tool to measure a case definition with some degree of accuracy that now allows us to track that data, model the system so we can back and fix it. So what about who's going to have BRD, right? So that's great. They're already sick. They're in the yard. But I told you the big problem is, right, I got to get Johnny or Susie or Jose on the back of a horse to find the suckers that are sick. Can we use this technology? Can we use an approach to sort this out at the time of entry and start to predict these high-risk groups versus non-high-risk groups, or maybe even individual high-risk cattle versus non-high-risk cattle? So you heard a little bit earlier today, it is very common practice when high-risk cattle show up in the yard, they run through the chute, and we're going to give them vaccines, deworm, implant, and metaphylaxis. Right? So we're going to pump antibiotics into those critters because we know that that consistently makes us economic money. It's a good approach economically. We will improve performance. Obviously, there are some questions about those kinds of practices from our customers today and the government and society in general. So we're saying, what can we do to arbitrate or fix that, and how do we make that more accurate? So we do use subjective rules when they show up today. So cattle that show up from the southeast in a Kansas feed yard with 9 different ear tags and 12 different colors probably are going to be called high risk. Those aren't a mystery to us. The ones that frustrate us are the cute little black ones showing up from Montana that 3 groups in a row were fine, and the 4th group, the wheels come off. So why does the 4th group from cute little blacks from Montana fall apart when the first 4 were okay? Those are the ones we don't understand. We understand the risk of buying southeast cattle that have horns and nuts and everything else. We don't understand the risk of buying calves off of big ranches from cow country that should be appropriate, that don't hold up in the yard. So we're probably not very good at figuring out who to mass treat, because we tend not to treat the calves that show up that we think have been appropriately backgrounded, because they have been. We may even have records on those. They still fall apart. So how can we be more accurate in that? Let me tell you, there's a lot of work going on in this area today. There's a tremendous amount of exciting technology coming in this area today. I don't know if any of it's going to work, but we're involved in numerous projects now trying to figure out how to screen these cattle. Some really fascinating high-tech robotic stuff that's coming that maybe will make this better, but we're not there today. So if we look at this, and here's the evidence to support this. This is, again, 250,000 treatment records over a year and a half, Of the cattle we treated, most of those 150,000, or 2/3 of them, were mass treated at the time of arrival. 1/3 of them were not mass treated at the time of arrival. So we do get pretty good, but we've got these down here. We've still got a relatively high percentage of cattle being treated. So how do we fix that one? Right, as I suggested, it's $30 a head plus today to poke those guys in the neck. When we were making $400, $500, $600 a head, $30 wasn't a big deal. If we're going to lose $300 a head, $30 is a big deal. So it costs a lot of money, and I think really more importantly, it's a societal responsibility, and particularly our customers saying to us, and I do not view PETA as a customer, I'll just be very honest about that. They do not buy our product. I'm not particularly interested in their thought process. But I am interested in our consumers, particularly Kroger, Walmart, McDonald's, etc., who do buy our product. And we have to think about what we're providing to them with respect to quality and additional attributes to that. And they are worried about these kind of things. And so at this point, all right, we have to think about that. So can we identify those lots? What did we do? So we took 25 pen lots, a couple thousand head of cattle, auscultated all those cattle at arrival, put the fever stick in the rear end, captured that data. Again, we categorized those cattle as individually high risk. So we did not metaphylaxis in the whole pen. We individually treated cattle that had a high lung score or a high fever. And they were treated generally, though not all 25 groups were treated the same, they were generally treated with macrolides at the time of entry, a couple of different macrolides. And then we followed those cattle for 30 days post-placement. And then we basically used multiple logistic regression to sort out lung score and pen level mortality to what happened, multiple linear regression, So we can identify it. So a 1% increase in lung score prevalence resulted in about half of that increase in morbidity. So even though we treated the sick cattle, the sick ones at arrival, we still had an increase in morbidity in those pens, but we only got about half of what the increase in here. So it's not perfect. We're making some progress. We can identify risk. We just aren't good enough yet at our risk identification. Hence, we've got to come back with some additional technologies so the thermometer and the lung score work if they're already been identified as sick, right? It's a positive bias. We've got an animal that we know is high risk. That technology is good enough to help us there. It's probably not good enough at this point to necessarily sort out the groups that are really bad versus the groups that are really good. To give you some context, if you're not used to this, morbidity is about 20% in high-risk groups, so a 0.5% increase in morbidity on something that's 20% probably isn't an earth-shattering movement. Now, what I will tell you is this technology is advanced. We're doing some different things today. That's coming. Hopefully that research is ongoing to help us improve this. But again, we can identify some of these risks. We just need to continue to move through it. So, I want to talk a few seconds here, just kind of a wrap-up. I want us to think about managing disease with the whole critter there, and that disease is really a function of a bunch of changes in that animal, not the presence of a bug. We tend to think of disease as, well, the bug is here. It's infectious disease management. Oh, it has manhemia. I would ask you today in the room to everybody put their hand up that probably is positive for Haemophilus influenzae if I went and sampled your tonsils. All of you. How many of you have pneumonia today? None, because you wouldn't be sitting here if you did, right? You'd be in the hospital going, I'm trying to die. So the presence of the organism in the host is not a very good indicator of the potential for disease status, and finding a pathogen in the lung is probably highly irrelevant to actually the cause of disease. We use it, not the cause of disease, the cause of death. We talk a lot about, right, that we'll sit up and say, well, that calf died of manhemia. No, he actually died because his heart quit beating. What made his heart quit beating? Well, it wasn't the manhemia in his lung. It was some giant systemic response that said, whoa, I can't continue to function anymore. So as we think about doing diagnostics, right, and pig guys are bad, like pig guys do diagnostics all the time. We fund 3 or 4 diagnostic labs. Roger Main loves pig guys at Iowa State, right? I mean, like, we send stuff by the bucket load to that dude. I don't know what we do with it, but we do it. Because we're very pathogen-focused, we're not host-focused. And so when we think about what's going on here, let's not spend a lot of time talking about this. Let's really think about what are we doing to the immune system. We've heard some great talks today about what some potential genetic modifiers of that are, what is really happening with stress, what's happening, potentially with mixing, and what's the role of stress, et cetera, there. And then let's think about what's happening really at this level of systemic changes and local mucosal changes in these animals and say, what can we do to support that? I think we're starting to shape our minds around the fact that antibiotics may be the least important thing we do to that calf when he's sick. And the most important thing we may do to that calf is actually how we take care of him. We have a phrase in the pig world, food, water, and a dry place to sleep. And if you don't get that done, let's not worry about the rest of it. We fail that routinely. I mean, I'm not telling you we're good at that. Anybody tells you the pig guys know they've got their act together, they know what's going on, is flat out lying because I haven't worked in the industry. It's a disaster. It's just a different kind of disaster than the feedlots. That's why we're all employed, folks, right? I mean, let's be comfortable about that up front here, right? I mean, Ralph Vincent, I don't know if you all know Ralph. Ralph was a famous swine veterinarian, the first guy to do consulting, and I was lucky enough to have him as a mentor when I first graduated. And he was my neighbor, and he said, Jim, every day you need to think up about getting up and stomping out disease, pestilence, and ignorance. But don't work too hard on the ignorance or you'll be out of a job. Chuckle, chuckle, chuckle. It's all true. But I think our job, right, is to say, what can we do to support these calves, whether that's on the cow, whether that's in the feedlot, whether that's in the dairy calf and the hutch. Right? These principles apply across all these systems. What can we do to support their immune system? And a lot of that is stressors. What can we do to minimize stress on those critters? And part of that is, how do our people handle that? I'm lucky enough to be partners with Dr. Tom Knopfsinger, and Tom would tell you what we do with our people-human interactions has a huge impact on this. And I think South Dakota State, Chris Chase just talked to him this morning, they're doing some things to really document that what Tom has always said is really true, that there's a massive and immediate response on local immune response on how we take care of these animals. And then what do we do to support these calves with respect to their systemic tissue health and really their local tissue health? And if we just think about measuring things like lactate in some of these calves, and we've got some nice evidence to suggest that lactate's a pretty good predictor now of badness that's going to come. And remember, lactate's measuring tissue perfusion. So if we have bad tissue perfusion, what's going on there? So how do we help support tissue perfusion, et cetera? So some adjunctive therapies and maybe less time on this. So I certainly appreciate you all listening today, and happy to take any questions.